All right, MED106, vital signs and emergency. So just patient interview and history. So pretty much the patient intake. We're gonna do a little psychology, and then we'll talk a little bit about documentation, the charting. All right, medical assistance role, of course, charting. So certain things very important, especially documentation rules. Conduct interview. So usually before the physician examines the patient, it's going to be the MAs, the nurses, doing the initial. Recording their medical history, aka charting. First step, doing the interview, establish that relationship. So it's just like in sales, once you get the patient comfortable, they open up to you easier. So if you build good rapport, kind of more like building a friendship rather than having that healthcare worker patient relationship, they tend to open up to you more. The appointment book. It is a legal document, so make sure you follow proper documentation rules as well. And usually we make appointments because a patient has an issue. So we call that issue their chief complaint. However, can we write in their chief complaint in the appointment book? Why not? Yeah, so your facility might use certain codes. That way it's more ambiguous, right? And you guys won't get hit with a HIPAA fine. It's a big one. Medical and health history, maybe including the family as well. So some things that you may not think of that's part of their health history is their employment history. Because certain jobs are more helpful than others. Certain jobs you're more likely to get injuries, physical, some stress or mental injuries. How long do you have to keep your appointment book for then, if it's a legal document? Remember, medical records, 7 years, right? So charts, 7 years. Financial records, is there money being exchanged with your appointment book? Will it back up charges? So some financials, you have to hold them for 10 years. So that's why you must document everything. Over documentation is okay in this case. So if there's something written, you can be fined. And of course, if it's not acceptable in your profession, then you may not be able to practice anymore. So they do have standards, ethical standards within the medical profession. Patients do have rights, but a lot of times patients forget their responsibilities. One big one is keep your appointments. Not only for your safety, but it's a business I'm trying to run. So if I can't run business, I probably won't be able to give you good health care. So focus on the responsibility and educate the patient on which responsibilities are very important. Definitely respectful of the patient's care. So if you build that friendly relationship, it makes it a lot easier. Refuse treatment. So patients should have informed consent. There's also implied consent and explicit consent. So implied consent is like if you're about to administer a shot and they roll up their sleeve, that's implied consent. If they make an appointment, right, they're implying that, yeah, they want to be seen by you, they accept charges, right? So that's implied. Explicit consent is if it's written down. They say, hey, yes, I want you to cut off my left leg. Informed consent is when we tell them about all the risks and benefits of the procedure, and then they still sign. They understand the risks. But you must be of sound mind. So if we already started, like, say, anesthesia, right? They're not of sound mind anymore. We're wheeling them into the operating room. They grab the door and they say, "No, I don't want to go through it." Do we have to respect their refusal at that point? Are they of sound mind? No, right? So they're seeing stars. So they're going through the surgery. It has to be of sound mind, of age. Cost of care. A lot of times there's a third-party provider. Most time patients want to know, what's my copay? What's my cost? And then confidentiality, of course. Are you familiar with advanced directives? So sometimes they call it like power of attorney or a proxy. So in the event that you, the patient, becomes no longer of sound mind, you want to set somebody to make the decisions for you. Or you can write down directions of what you want to happen to you in those cases. Get it signed, get it notarized. Can you get a copy or the original in the patient's chart? Is a copy okay, or do you have to have the original? You're gonna most likely need the originals. So try as any time you can. Try to get the originals. Yes, when we interview the patient, don't withhold anything. If a patient withholds information, it's gonna affect treatment outcomes. And then make the patient part of their healthcare decision. They take ownership of their choices as well. Follow physician's orders. And then follow up on any insurance claims. 0101. What happens on January 1st for people with insurance? Usually updated. So there might be an updated group number, plan number, policy number. So in November, October, November, everyone elects their next year's benefits and it kicks in January 1st. So don't work January. You'll have a headache. Just kidding. All right, HIPAA. Make sure you spell it appropriately. Health Insurance Portability and Accountability Act. So look at that fine. Look at that sentence. So you can continue health coverage, but we don't want you to be discriminated because of your health history. So it's kind of like a double-edged sword. So HIPAA established protected health information. So you have to tell the patient how you use their information. They must sign an acknowledgement, and that acknowledgement must be kept for 6 years after their last treatment, so after their last service. So if they went 5 years, 360 days, you're going to have to keep it for another 6 years. %, right? That 80-20 rule. Communication is 20% what you say, and it's 80% everything else. So open communication. So open posture, eye contact. Well, there's some cultures you don't want to make prolonged eye contact. And then other cultures, if you are not 1 inch nose to nose, they do not feel that you have their attention. So if you step back, they're going to step forward because that's just their culture. So in most society, right, there's a couple zones, right? Personal space is about 3 feet. Conversation room is about the other 10 feet out from there. So even though what you say is awesome, perfect, you follow the script, if your body language does not match, it might make the patient uncomfortable. Practice effective listening. So you can nod, repeat things to clarify understanding. Can you touch a patient? Is touching verbal or nonverbal? Is touching verbal? To touch somebody, do you say it's nonverbal, right? So because it's nonverbal, it can be interpreted wrong. So there's some touching we can do, right? Like touch them on the back of their hand, their forearm, all right, pat them on the shoulder. Can you give them a hug? Give them a kiss? Right? No. So if there's any touching, just explain why you're giving them a hug. I'm giving you a hug because I'm so proud you finished your treatment. Right? That way, there's no confusion. No confusion. Right? I'm friendly. I'm not hitting on you, right? And then just review at the end. Sometimes patients get mad if you get, oh, that's the end of our time, and you just leave. So they want some kind of closure, like, okay, so we talked about this today, I want you to work on that. It just builds better rapport. Don't say, oh, time's up, class is over, everyone, get out. So just common interview skills. So look at the patient, pay attention, and then for clarity, reinstate. Don't assume what the patient's trying to say. And when you chart, you want to chart the exact words the patient said. Patient stated this, this, and this. They could have meant something different, but that's not for you to interpret. Just verbatim what they said. So 80% of what we communicate is through that. Right? We kind of lost it, but the animal kingdom, right? They don't have a wide language, wide vocabulary, but their body language speaks volume. Broad knowledge base, definitely. They're going to ask you questions from out of left field as well. So it's just with time and experience, you'll be able to handle it better. Before, do a little research. That way you know the appropriate questions to ask. Plan the interview, yeah, definitely. What you can and cannot ask. And then before you start, just let them know what's going on. I'm going to take an interview, ask you a few questions just to see where you are. Open-ended. So leading or open-ended questions, let the patient to talk more, explain more, and direct what they want to talk about. So avoid anything that can be answered with one word, yes or no. So here's good. All right, they're pointed towards each other, close enough, and seems to have good rapport. Close the door. Privacy. No worries. And then you don't want to probe, right? So probing questions are not therapeutic. So when a patient starts to give you clues, like they don't want to answer questions, they're kind of prudish, you're answering sexual questions, their sexual history, you don't want to probe. You don't want to ask why as well. Those are non-therapeutic questions. Can MAs diagnose? No. You're going to have to refer them to the physician. Can MAs release lab results? All lab results? What type of lab results? Good lab results? Bad lab results? Any? So, so most of the time, make sure the physician reviews it first, right? And then if the physician says, yeah, go ahead, yeah, that's up to the physician. But you don't want to release any lab results, whether they are good, definitely if they are bad, right? So just remember your scope of practice. Some are routine. Yeah, some yeah, privacy, you want to make sure physician clears it. But some are routine, like depending on your practice, what they do. Some are just routine, you can give them the results. Your TB screening's negative. Yeah, right. That's not going to be so life-threatening. All right, good stuff. Effective. So we already mentioned open-ended questions. You don't want just yes or no. Let them talk, let them speak. Right? Hypotheticals. That way, it's kind of like testing them. Like if your blood sugar drops in the middle of school, what would you do, right? So you're kind of testing their understanding, right? Testing their knowledge. Mirroring, that's repeating to make sure what they're commuting exactly what you received. And then refocus the patient. If they start going off tangent, just direct them back. Lead them, but let the patient, open to what they want to talk about. Not too bad. Ineffective would be close-ended, just those yes/no questions that doesn't really allow the patient to explain. Challenging the patient. You don't want the patient to seek approval from you. Like you don't want them to choose what to do based on your opinion. So here, make sure you keep that good rapport with the patient. As mentioned, probing. You don't want to invade their privacy. You only want them to offer information. If we start agreeing and disagreeing with the patient, then what will the patient keep on trying to prove or try to choose? The right answer. You have this option A and B. So if the patient always says, is this a good choice? Then they're really going with what we think is the right thing. So we never want to agree with them or disagree. What percentage is nonverbal? Yeah, a majority of communication is nonverbal. Anxiety, fear. How can you tell that a child has a little bit of anxiety or fear? Mild. Little kid, toddler, walks in the room, what do? Yeah, they stare at everything, right? If you are an unfamiliar face, they lock at you. They're like, I know mommy, I know daddy, but who are you, right? So that's about 6, 9 months, right? You start to recognize. So that's how you know a child has a little bit of anxiety. Same with an adult. If they start focusing on things, their hands start rubbing each other, then you got to recognize different levels of anxiety and what type of directions you can give. So at mild anxiety, yeah, you can talk to them normally, right? Once they get more and more anxious, they're going to be able to comply less and less. So for moderate anxiety, just give them choices. Sit or stand. Do you want to sit or stand? But when they have anxiety off the charts, all you can do is relax them. So just tell them stop. That's it. First thing to do, get them to stop, slow down. And then once you get them down to a mild level of anxiety, that's when you can continue on the interview. So yes, the children will stare at you. Severe, they're not going to be able to focus. They're bouncing off the walls. Depression. Well, depression's kind of weird, especially in these guys, right? Because they're normally up and down, sideways. They sleep a lot. They don't sleep a lot. They eat a lot. They don't eat a lot. They hang out with their friends a lot. They don't. So it's kind of hard. So you're going to have to really pay attention over the the long haul when it comes to these kids and the tweens. It might be substance. Ooh. So I don't know. They keep on saying every generation kids have more and more access to substances, but I think it's always been the same. Kids are going to have access to substances regardless. So it's best to, I think, educate them. That way they can make at least a better choice, a better informed choice. But the signs of addiction and substance abuse can sometimes be confused with depression. Same thing. Weight loss, weight gain, irritability, hanging out with friends a lot, sexual activity changes. Middle age. What year's middle age now? When am I supposed to get my Porsche?
30?
What?
30?
Middle age is 30? I thought middle age is 40s now.
65?
So I'm only living to 65. I want to live at least to 80. So I'm getting a Porsche in a couple years. I'm telling everybody.
Really?
No, but I should be, right? Because that's the midlife crisis. So that is when people look back and say, "Oh, I should have done this. I should have." So that's why I'm getting my sports car, right? The elderly. What's senile? You don't know what that means? When you call an old person senile? It's not crazy. It's just that their mental capacity deteriorates. So it's not because they're going crazy. It's just they're slowing down. They're mixing things up, right? So it's not mental illness. It's just they're slowing down. That's all. Their brain has to slow down too. Their body's slowing down. Abuse. Your role is to report, report, report. We do not determine if it is or is not. If it is found that we did not report, who gets in trouble? Yeah, the person who did not report. So some things you want to watch out for. Different stages of healing. Bruises. Fresh bruises. Purple, green, yellow bruises. What's going on here? Why did you wait so long to get them in? Why didn't you bring them in at the first bruise? Right? Children with a lot of broken bones while they're young, especially spiral fractures. What happens when we have a spiral fracture? You grab and you twist their arm, right? Different types of burns. Cigarette burns on the bottom of their feet, right? If you have kids that are wearing clothes to cover up their whole body when it's hot outside, what's going on? What are they covering up? So your job is not to determine, your job is to report. And it is mandated by law that you report. You get in trouble if you don't. How about sexual abuse? Do you have to report it?
Yeah.
Do you have to report it?
Yes.
Yeah. So for certain diseases, certain have to report it. Again, it's not your job to determine if it was rape or not. It's your job to report. Skull fractures, ooh, burns, multiple broken bones, bruises at various stages, certain things definitely want to look at. Other signs of abuse, neglect, right? Example, hey, why ain't your kid up to date with vaccinations? Are they like physically harming them, emotionally? Physically, no, but it's neglect, right? You didn't get them all their vaccines. Didn't get them all their appointments. What else are you missing? Should you report? Yeah, your job is just to report. They'll determine if it's neglect or not. Right? Dehydration, not eating, not feeding your kid. Yeah. One thing for children is bathtub burns. It's something called the donut. Doughnut. So the donut burn is when you put a kid in a bathtub that's hot when their butt touches the bottom, right, it doesn't burn, but everything else that touches the water will burn, right? So when you see that mark, that round mark where there's no burn and there's burn everything else, then you know that was a submersion burn. Wherever they're touching their butt on the bathtub that's not hot, didn't get burned. If they dunk their foot in, right, then it'll look like a sock that's been burned. Splashing, you know, splashing is an accident burn, right? More likely a splash is an accident burn. But if you see those patterns, then definitely report them. The rates are crazy, like sexual assault. Women, I think it's like a third of women experience it throughout their lifetime. And then elderly, a lot of abuse, um, emotion, physical, psychological, and neglect as well. If they have bed sores, what's going on if they're starting to get bed sores? Yeah. So they're not being rotated, they're not being changed, the humidity's not being checked. Maybe antifungal medicine isn't being administered. So just report everything. You won't get in trouble for reporting. A lot of women don't want to report sexual abuse because they don't want to relive it. Right? That's one way. And also a lot of them feel shame because they feel that I let myself get raped. So a lot of psychological and emotional damage as well. All right. So you give a shot to a child. Should they cry or not cry? Yeah, right. If they didn't cry, what does that mean? I'm used to it. I'm used to pain. Right? Let's see. Um, the child doesn't want to go home. Right? Or the child is like on their best behavior. Because kids are going to act out, they're going to cry, but if the kid's in the best behavior and they look like they're in fear, that's because, yeah, if I'm not at my best behavior, what's going to happen afterwards? I'm going to get a beating. Just watch out for those little clues. Elderly again, they may be in fear. Let's see, substance abuse vary. So alcohol, very dangerous because you can die from withdrawal. Other substances, even heroin as they depict in the movies, it's not going to lead to death because alcohol suppresses the brain activity. Without alcohol suppressing it, your brain goes haywire, gives you seizures. Exact words as mentioned, put them in quotes to let everyone know. Clarity, so no ambiguity, use correct abbreviation. Completeness, everything's there. Conciseness, short and to the point. Chronological order, depending on your site, it might be reverse chronological order. Of course, HIPAA requires confidentiality. Patient registration. So if it's a new patient, try to get them in an hour before or send the new patient. Mail it to them. That way it's already filled out or mostly filled out. Once they get in, you can process them quickly for new patients. Ask their history. Test results are in their chart. And then any records like discharge papers from nursing homes or hospitals, you want to make sure you have those as well. So what's in or how is it? It depends, right? It depends on the system that you're using. Usually what's not in the patient chart are financial papers. It's usually separate. So everything else except financials you'll find. Right, SOAP. Source, sorry, subjective data, objective data, assessment, and then plan. There is an expanded version of this, but usually when a patient comes in, subjective data is going to be what they're complaining about, their chief complaint. I have a headache, a big, gigantic headache. So they come in, that's their chief complaint. Objective data is what they come in and I find out through exam. You got a huge, gigantic headache because your blood pressure is like 500 over 300, right? Of course you're going to have a headache. So these are things we can measure and physically observe ourselves. Subjective data, the patient tells us, we can't measure it. So that's the main difference. Assessment, so everything leading up to the doctor's diagnosis, and then we have their plan of action, which might include drugs, surgery, and other treatments. Source-oriented medical records. So this is usually not used because of the organization. You can't follow a particular condition very well because it's kind of jumbled. If it's the radiology that discovered the problem, then you list it under that. If it was the doctor, you'd list it under that. If it was the patient themselves, you list it under that. But it's not chronologically organized. A better system, and what's usually going to be used, is problem-oriented medical record. So we just number it. This is your first condition. It was the flu. Then you had a broken nose. And then guess what? You got the flu again, right? So there's no confusion. Are you talking about the first flu case or flu case 3, right? So it's easier to follow. So it doesn't matter. There'll be computerized systems. And again, make sure you follow all their HIPAA rules. Can you use TIW? What does that stand for? 3 times a week. What is it mistaken for? 2 times a week, right? How about this? Can I use this symbol? No. Microgram. Is that correct? No. How about QOD? Can I use that? What does that stand for? Can't use it, right? So make sure you know the acceptable abbreviations, non-acceptable, and your facility will have their own list as well. The Joint Commission. So refer to their do not use list. And I just listed a few of them. Patient medical history, including family history, because some are genetic conditions and some are epigenetic. Do you know the difference between genetic and epigenetics? Your genes. Epigenetics are which genes are turned on. So first, your family members are going to have similar genes, right? So you might get breast cancer like Angelina Jolie because she has the gene. But if none of her family member ever got cancer, would she have removed her breast? Probably not. But because her family members, aunts, mother, I think, all got breast cancer, then that's proof that those genes were turned on, and then she did something about it. So that family history will help us. Interview technique, provoke. PQRST. So what causes it? What do you do that relieves it? Oh, doc, it hurts when I do this. Doc goes, well, don't do that, right? quality and quantity. So let's say it's pain, right? So what type of pain is it? Is it numbing pain? Is it sharp? And how often does it last? Does it radiate? Right? It hurts in my neck. Does it move anywhere else? Yeah, it hurts from my neck down to my wrists. Or it hurts from my buttocks down to my knee. Right? So if it's your buttock to your knee, sciatica. Right? If it's your neck all the way down your arm, maybe it's a cervical nerve. So for us, pain is 0 to 10. So 0 is no pain at all. 10, the worst pain you ever felt. And is that objective or subjective? Can we measure it? Can we measure it? Yeah, so it's subjected to interpretation. Very good. And when does the pain occur? When I wake up and when I do this. So stop doing that. Electronic health records versus electronic medical record. Do you know the difference? This is for one facility. So one doctor's office will have all of your information for all your visits at this doctor's office. But you don't just see me, you see another doctor, a specialist, a hospital. So all of your medical records all together, that's your electronic health records. And if people have access to that, definitely they can discriminate against you. Los Angeles County, 40,000 Maria Sanchez's. Have fun. Don't work in LA, I guess. So you're gonna have to go to middle names, maiden names, birth date, but then again, a lot of chances, same middle name, same date of birth, similar. Yeah, you're gonna have to use other identifiers at that point. Progress notes, reverse chronological order. Also, if there's any lab results, make sure the physician signs or initial them before you put them in the patient's chart. They must see them before you put them in there. If you stick them in their chart before they reviewed them, that may cause medical error. Poly, many. A lot of medications contain same ingredients. A patient may see a specialist or a dentist, chiropractor that prescribes similar ingredient. Right? Vicodin has Tylenol, Percocet has Tylenol, NyQuil has Tylenol. So you can double up, triple up without knowing. So get that current list and also any supplements, herbs, anything else. And you have to remind the patient, are you sure you're not on birth control pill? Because sometimes people forget because they do it all their time and they don't consider it as medication anymore. Personal data, yep. Contact info. And then for every appointment, their chief complaint. So past history, so all their health problems, medications, and allergies. So the first thing you do is you always ask, before you do any treatment, administer any medication, you always ask again, medication and allergies. Medication and allergies. All right, we already talked about how family history might help with genes and epigenetics. I mentioned earlier, certain jobs are stress-filled. Certain jobs are seasonal, right? So stress or weight gain, all those issues might come seasonally. All right, not too bad. Patient interview and history. So for the next chapter, we'll cover vital signs.